Hello, hello, friends. Good morning, good afternoon, good evening to wherever you are in the world. We have today with us the Lincoln Medical Center in New York, who will share a lot about their program. And they also brought a case for us to discuss. And I'll be co-discussing the case today with Austin and hopefully Jimena. And I'm an IMG. I graduated from medical school in Turkey. And now I reside in New York City waiting for my match results. And I will pass the mic to Dr. Austin to introduce himself.
Well, hello, everyone. Good morning, good evening, good afternoon, wherever you are in the world. My name is Austin, one of the Academy members. I work and live in Texas, but really excited about being back for another IMG VMR. And it's so awesome that we can highlight the IMGs and all the wonderful things that they do and how amazing they are. So I'm just excited to hear the case and learn more about the program.
Thank you very much for being here, dear discussants. And next we have Dr. Alberto Romero Garcia and Dr. Amar Borja. Please tell me if I said your name wrong. Would you like to introduce yourselves and tell us what do you like doing outside of medicine?
Sure. First, thank you very much for the invitation. As I said before, we feel very honored to be here and to help with the case, to share our journey. I think that is a very nice way to get a network, to get more perspective. So yeah, and we're very glad. So my name is Alberto. I'm from Ecuador. I'm a PGY3 here at Lincoln. Things that I like to do outside the hospital, mainly running, hiking. Those are my riding the bike, also my favorite activities out of here. I also like to read a lot. Most in between reading and hiking and running is what I spend my time.
Hi everyone, my name is Amar Vora. I'm an IMG from India, and I'm currently a PGY2 in internal medicine at Lincoln Medical Center. Outside medicine, generally I like to watch a lot of TV shows, basically sci-fi. I love Star Trek. That was also in my eras as my hobby section. What do I like to do? Being in New York City, there are a lot of events that always are there. I like to attend a lot of concerts. So like since I have joined residency, I've attended like 4 or 5 concerts already. So yeah, I like those things.
That's definitely true about New York.
Yeah.
Going out, there's so many activities, so many events all the time that you can. Restaurants, food. If you like food, there's so many options to go to, which is something that we really enjoy about living here.
Thank you for all that. It's really nice to know that outside of medicine, you can have like time to do your hobbies and stuff like that. So without further ado, we can start with the case, and our dear discussants will be ready for you whenever you are ready. Thank you, Dr. Vijay.
All right, so our case is a very interesting case. It was presented a couple of months ago, and hopefully we all can learn from the discussion. So we got the admission message from the ED. It's a 23-year-old male presented with 2 weeks of worsening shortness of breath and cough. Do you guys want to start asking questions or give more information?
Yeah, I think we can start discussing here with the chief complaint because I think we have plenty of information here. So this is a very young patient, a 23-year-old male who had shortness of breath and cough for weeks. So when I look at these two chief complaints, I'm trying to find like which one I should start tackling first. And in that, I either look for which one is more emergent, so that I can like start attending to that chief complaint, or which one has a narrower differential diagnosis so that I can make progress from there. And when I think about cough, it's not that specific because cough can be secondary to many causes. There can be some pressure to the tracheobronchial tree from the outside, or there can be something within the tracheobronchial tree that's impeding the airflow into the lungs. So it can be because of many reasons. But when I think about shortness of breath, that localizes the cough for me to the lungs, to the lower respiratory tree. And shortness of breath 4 weeks in a young patient is a little concerning, because if this was because of a, I don't know, an respiratory tract infection, for example, I wouldn't expect it to be that prolonged. I would expect it to go for maybe a week or a little over weeks. Of course, like the cough can linger, extending beyond a week, but 4 weeks, I'm not sure how many weeks exactly, but it sounds a little concerning for me. And in shortness of breath, my differentials include the pathologies concerning the lungs and the heart, the cardiopulmonary tree, first of all. And then I also think about if the shortness of breath is present while the patient is resting or on exertion. So as Rabia and Reza and many other attendings taught us numerous times in CP solvers, I would take the patient for a walk, for example, to assess if the shortness of breath is exacerbated by exertion, or if the patient has shortness of breath both while resting and that increases while the patient is exerting themselves. So in this aliquot, I'm leaning more towards the potential like pathologies in the lungs or the heart. And I'm additionally thinking of anemia here that could cause shortness of breath, but that wouldn't explain the cough. So that's lower for me in the list. Maybe the patient might have like pre-existing anemia. We'll find out in the hematology, the complete blood count section. And then I'm also thinking about other metabolic endocrine disorders like thyroid disorder, for example, that could cause shortness of breath. But of course, the cough would be, again, less expected with a pathology like that. So hearts and the lung pathologies are on the top of my list as of now. And I'm very excited to learn from Dr. Austin.
There's nothing left to teach. I mean, that was incredible. Like it was so, you made so many incredible points. And then just to highlight a few of the really nuanced points, you said, hey, how do I make progress in a patient and what matters most? And you said, what's the specificity of the chief concern and as far as how I can make progress, or what's the acuity of the chief concern in deciding how quickly I need to make progress. So that was a really nuanced point. The other thing was understanding that, most younger patients with a cough, the base rate is that they have a virus or something else relatively benign. We can go through sort of our cough schema that potentially, but most of those things do not overlap with dyspnea in a young person necessarily, right? So the combination together is one that has a particular flare of severity. And I think that you highlighted that really, really nicely. And, these exercises are artificial. So in a sense, like we're never going to stop with a patient coming with shortness of breath and cough and just talk with them. Okay. Or let's just step out of the room and talk through the differential diagnosis, right? So realistically speaking, as soon as you read on the patient's chart or you get that page from the ER about the admission that says shortness of breath plus cough, then I think you're, just as you said, you're already localizing yourself to the lungs. So when you go to see the patient, you're going to be tailing your history based off of that, I think. And if that doesn't become fruitful, then you're going to go back and revisit which one of those things has a differential diagnosis that you can follow and you need to make progress on. And the most specific one being shortness of breath, just as you said. And then you started to outline, what are the causes of shortness of breath that don't necessarily cause cough. And maybe the cough is a signature from something else that happened. And now the shortness of breath is a new issue, or is completely unrelated to what was happening. Maybe they have high blood pressure and on lisinopril and they've had cough for 3 years. You don't know. So I think that was really, really nuanced. I think the only other thing I can say, and I've been trying to be better about this, is that I think understanding the host is going to be really, really important, right? So a young person coming with a shortness of breath and cough, this was a 70-year-old with shortness of breath and cough, would probably be like, okay, community-acquired pneumonia, right? And I'm going to get the x-ray and do all this stuff. But a young person, as you said, probably shouldn't have dyspnea from run-of-the-mill things that cause cough. And so understanding the host is going to be really important, whether or not they have an immune issue, so they have immunodeficiency or they're immunocompromised in some way, or they have a chronic pulmonary condition that predisposes them to infection, so asthma or CF or who knows. exactly what we see. But amazing, incredible start. But let's hear more.
All right, I think that was a very comprehensive and systematic overview of the main points. When you get an admission, you get this sort of information. So focusing on these topics that you guys just mentioned is very, very important. And specifically, the point of the dyspnea, as you guys mentioned, is pretty important. And I think also the chronicity of it was 2 weeks of these symptoms. You don't expect if a guy this young having shown us in 2 weeks, like how if he had an infectious cause, how fast it has been developing. So the rest of the history is focused on the chronicity of symptoms. Once we started him asking more questions, we find out actually that everything started with general weakness and fatigue around 1 month ago. It has been getting progressively worse. He has been also having some chills on and off. Regarding the cough, it's a productive cough with white sputum that developed in the past 2 weeks. The shortness of breath is exertional. The patient described at some point that it has been difficult for him walking to the bathroom, and at some point has had to stay in bed for most part of the day because of the shortness of breath and also the weakness and the fatigue. When we keep asking questions, turns out 1 week ago, he had an episode of blood-tinged sputum. This scared him a lot, so he went to an emergency department in an outside facility, and they diagnosed him with pneumonia, and he received some antibiotics, amoxicillin and doxycycline, which did not help. He's still having progressively worsening shortness of breath, so he comes to our hospital with these symptoms. On the pertinent negatives, he does not have any recent troubles, no sick contacts, no chest pain on exertion, no orthopnea, no palpitations, no nausea, vomiting, abdominal pain or diarrhea, or constipation, and also no myalgias, no urinary symptoms, no dizziness, or no other neurological symptoms that he could have noticed.
Okay, so now incorporating this new information, what I'm hearing from you is that the patient has had generalized weakness, fatigue, and chills for the past 1 month. And then 2 weeks ago, the productive sputum started. And then 1 week ago, the patient had blood-tinged sputum, which prompted him to go to a urgent care. And then he got diagnosed with pneumonia and treated with antibiotics. But the shortness of breath still continued over that period, even after the treatment with antibiotics. And the nature of the shortness of breath is more like exertional in nature. So this is making me more and more worried about this patient, because it seems as if the shortness of breath and cough has a inflammatory tail to it, with the generalized weakness, fatigue, and chills that has been going on for the past 1 month. And on top of that, there's productive blood-tinged sputum for the 2 weeks. So I'm getting really worried about the patient. And so I'm trying to prioritize what to tackle here first. With the blood-tinged sputum, the hemoptysis is not that worrying for me, because it can accompany a lot of lung pathologies. And as we know, the lungs are supplied by the pulmonary artery and the bronchial arteries. And usually the source of the bleeding comes from the pulmonary arteries, which is like lower risk bleeding. And it's low pressure circulation, and the bronchial arteries are the higher pressure, and the bleeding is not like small oozing type, but like spraying and worse. So here it doesn't seem that concerning to me, the hemoptysis, the blood-tinged sputum part. But the generalized weakness, fatigue, and chills for 1 month is making me worry about infections, the infectious bucket, and not like our usual infections, like the acute bacterial causes of infection. It seems as if this patient might have a more atypical cause of infection. It can be atypical pneumonias, maybe a typical bacterial infection of the lungs, or some other pathogens. It can be, I'm not sure, maybe fungal pathogens, or some other pathology that has been lingering for a longer time than I would expect in a community-acquired pneumonia. And the patient already received treatment for CAP, which didn't improve the symptoms. The exertional nature of shortness of breath is, again, making me focus on the cardiopulmonary apparatus, because that's how we get, especially the heart maybe here, because that's when we get shortness of breath on exertion, but I'm not sure. But still, I'm in the lung and heart space still, and prioritizing the more atypical infections of the lung that's causing the inflammatory tail for the shortness of breath and cough. What do you think, Austin?
No, I mean, again, that was incredible. I really don't have anything to add. I think you layer on everything so well. And I guess the only thing that sort of stood out to me more than everything you already said was just the severity of the dyspnea, right? This is a 23-year-old guy, presumably normal. Before this, we're going to learn more about that. But he's saying that he can't even get out of bed to move, right? That alone is so profound that, just as you said, I will be terrified about what's going on with this patient, and we'd be doing, a lot of things to try to figure out what is happening. I was thinking to myself, okay, does that severity alone help us make progress about where in the system is the problem? And I really couldn't come up with too much. If I just reflect back on the cases I've seen, how many patients with community-acquired pneumonia are so debilitated that they are stuck in bed? Not that many of them that I can recall. Again, especially in a young person, I think that also speaks to there's some underlying issue that's happening that we have not recognized yet that speaks to the severity. But even older patients that come to the hospital, usually they're not bedbound by the time that they get there related to their community-acquired pneumonia. The other thing, as you said, is that we've had what seemingly appropriate treatment for community-acquired pneumonia, but with beta-lactam and something to cover atypicals for an expected course, and most patients should respond within a day or two to antibiotics if this is community-acquired pneumonia, and the patient did not. And so it'll be nice to know if there was imaging to corroborate that there was a lesion, or if they sort of empirically treated for pneumonia, because that might help us a little bit. But the other thing I'm wondering is that, okay, we had some diffuse syndrome happen. So as you said, this person was first started off with fatigue, right? Most bacterial infections are not going to start off with diffuse symptoms, right? So either we have and Robbie gave a really nice explanation of this a while back, but the idea of an infection causing more diffuse syndrome, if it's a bacterial, typical pyogenic infection, usually that's going to start by localizing somewhere and then become diffuse if it becomes like sepsis or something like that. But if there's an external thing that happens, because most bacterial infections come from a commensal organism or things that live there that then go into a place that they shouldn't go. This suggests like there was a viral syndrome initially, or there was a sort of tick-borne related illness, for example. I suppose fungal infection could fall into that category as well. But again, I think we're coming back to, we got to understand the host. And we also talk about, the bad luck, the bad genes, and the risky behavior. And I think that's an important thing to layer on as well. But all of that really comes down to understanding the host and history. I think history will be key in getting us the answer to this and almost any patient concern. So let's hear more.
Right. So the way you summarize it is very well. And you're right. The clues lie in the history and the physical exam. So we'll come to like his past medical history now. So he told us that 5 months ago, he started to have pain and tightness in his wrist. He went to an outside clinic where he was diagnosed with carpal tunnel syndrome. Around the same time, he also developed a rash in his scalp, and he was diagnosed with psoriasis. But he was on no cream or any treatment for that. The only thing that was prescribed to him was gabapentin for the pain. Coming to his social history, so this gentleman used to stay in the Dominican Republic until 2017, and then he moved to New York City, and he has been here ever since. He has not gone anywhere, and he has not moved out of New York. He denied any sick contacts. He has one female sexual partner, and since year 2022, and they don't use any barrier protection. He used to work as a forklift operator, but because of his wrist pain, he had to stop working. Um, his personal habits, he told us that he used to smoke marijuana, but then he stopped 5 months ago. And he denied any tobacco use, alcohol use, or any other illegal or illicit drug use. Family history is significant for diabetes mellitus in his father and grandmother. Medication-wise, as we discussed, that he was taking gabapentin and he denied any allergies. Okay, so we'll move to the review of systems. So like we said, we'll start from the constitutional and we'll go system-wise. So he told us that he's been having night sweats on and off for the last 1 month, chills, decreased appetite with early satiety, associated with a 20-pound weight loss over the past 2 months. He had a facial and scalp rash. Respiratory system showed that he had shortness of breath, which was again worse with ambulation. Productive cough, productive of white sputum, occasional specks of blood. Cardiovascular, he had this right-sided chest pain, but it was more pleuritic rather than typical cardiac chest pain. But he denied having any palpitations or the typical cardiac left-sided chest pain radiating to the shoulder or the arm. No problems with the abdomen or the GI system. Coming to his musculoskeletal system, like initially he said that his wrist felt tight and he found it harder to make a fist, and he had pain in several small joints of his hands. Neuro was fine, no issues there. So to summarize the timeline of his symptoms, 5 months ago, developed stiffness in his hands and fingers, went to an outside clinic, diagnosed with carpal tunnel syndrome. Also at the same time, he had a rash in his scalp and diagnosed with psoriasis. 4 weeks ago, started to have this generalized weakness, fatigue, decreased appetite, and early satiety with associated weight loss and continued joint pains in his hands. 2 weeks ago, developed productive cough with worsening shortness of breath, along with pleuritic chest pain. 1 week ago, had episode of some blood in his sputum, went to an ED and discharged on oral antibiotics. And then he comes to our hospital for further evaluation because his symptoms were not getting any better. Okay. So what do you guys think now?
Thank you so much. This is such a rich history, and I'm just trying to think about everything that you gave us first separately, and then I'm trying to find a common unifying syndrome that could include all of these. But I'll just go one by one first with what you have given us. So when you mentioned first the carpal tunnel syndrome 5 months ago, or it was diagnosed with carpal tunnel syndrome, but maybe it was something else, we're not sure. I was first I couldn't incorporate it in the grand scheme of other symptoms, but when you gave the information that the patient works as a forklift operator, it made sense that maybe because of using the equipment that vibrates often as a forklift operator, that could be contributing to the hand symptoms that the patient is having, both the carpal tunnel syndrome and the joint pain in the hands. With the rash on the scalp that was diagnosed as psoriasis, and with the rest of the patient's symptoms with night sweats, chills, weight loss, shortness of breath, and productive sputum, I started thinking about would this patient maybe have a immunodeficiency syndrome like CVID? Given the patient's young age, and CVID can be diagnosed later on in life. It doesn't have to be diagnosed in childhood. That kind of became one of my considerations. With the 4-week history of night sweats, chills, weight loss, I think that's the most concerning still of the symptoms for me. And since this has been going for such a long period of time, 4 weeks, I started thinking about systemic diseases that could cause that. And one of my considerations was perhaps a vasculitic condition like GPA that could be causing a problem in the lungs, and there are skin findings too. But we didn't hear anything about the kidneys, like if the patient has hematuria or anything like that. But maybe you'll give us more information in the urine analysis. So I will just hold that thought off for now. And it even raised the possibility of a malignancy for me in such a young patient, even though I wouldn't expect like typical malignancies to develop. There are still some malignancies that could be happening in young patients. I'm thinking about like lymphomas here, especially involving the lungs. And I'm not sure. I would like to hear more from Dr. Austin.
No, I mean, again, I think you're all over it. I mean, it's amazing to see like how much progress you've made. And again, I just reflect back at what I was like at your stage of training, and it's just like, it's mind blowing how much better you guys are than I was. I mean, it's superb, absolutely superb. But, I think, as you said, we have flavors of inflammation, which you mentioned before. I think that's just further strengthened by all the information we got, right? The person is having night sweats, they're having unintentional weight loss. It's again, just sort of speaks to the severity of the body is on fire in some way, shape, or form, and we need to figure out why it's on fire. What are our buckets of inflammation? Let's go back to the rock of the schemas that began with the CP solvers. So infection, malignancy, autoimmune drugs, and endocrinopathy, just as you said. I think endocrinopathy, there's a very select conditions that really cause an inflammatory syndrome. We're really not getting the flavors of that right now. Drugs, the patient doesn't take any medications besides what they recently received. And the time course is so long that unless they were taking certain herbal medicines, vitamins, supplements, like with rare sequela related to that, then, probably the drug category is off the list, right? So we're the infection, malignancy, and autoimmune categories. The base rate would say, as you said, that probably this is not malignancy. So now we're infection and autoimmune. And the longer that a syndrome goes, the less likely it is to be an infection, right? Especially in someone who has an intact immune system, at least to begin with. So I think we're favoring the autoimmune bucket right now, but absolutely have not excluded the infectious category yet. But I think that's where we're at, just as you said. So how do we make progress within the autoimmune category, autoinflammatory category? And I think it's just as you did, like, how do we synthesize everything together? And one of the really nuanced things you did to say, hey, I'm going to take every diagnosis this patient has received at face value, and I'm not going to necessarily commit them together. And so I think I've personally fallen into this trap many times where the patient will come to me and say, oh, I have carpal tunnel, or I have this diagnosis or that diagnosis. But and this is no offense to anyone, but everything that you should see in a patient is a trust but verify approach, whether that's something you hear from the care that they've received previously or from the patient themselves. Like, oh, yes, my diabetes is doing okay. I'm glad to hear your diabetes is doing okay, but let's go ahead and check your A1C and see how it's doing. Because everyone's perception of what is good is different, and everyone's understanding of their medical conditions is different. So it's very important to verify. And so I think we took carpal tunnel, but now we're hearing that there's a flavor of tightness and stiffness, sort of an inflammatory arthritis, it sounds like, right? We're having that sort of morning stiffness that seems to persist. That's how I sort of translated it to me. So instead of saying that this person has carpal tunnel, what you could incorporate and say, oh, there's an infiltrative disease going on, which, I think we can invoke later on down the line if we could determine this to be carpal tunnel. But I'm translating more of what they're saying into synovitis or a joint issue. And this is the same thing goes for the rash, like there's not that many things that cause this conglomeration of syndromes plus a scalp rash. So I think psoriasis is absolutely fair. But again, every autoimmune diagnosis is a working diagnosis, right? I've seen many patients who come in and say, oh, I have RA, or I have this, or I have mixed connective tissue disease. And then later on they develop lupus or whatever it may be. So, and I think there's so much overlap, and there's so much of the spectrum of disease, and we like to put them into these nice categories, but really most patients don't fall into these specific categories. Unfortunately, this is how we currently treat patients. And I think this speaks to why some patients do really, really well on a certain medication. Other patients with the same disease don't respond at all. And I think that's because we don't have a clear understanding of what these diseases are. And Yusuf presented a very, very nice case like a few years ago now that taught me this point. So I think every diagnosis that a patient receives is a working diagnosis, in particular for autoimmune conditions. So nonetheless, I'm overlapping synovitis, rash, constitutional symptoms, dysphenotic exertion, cough, and pleuritic chest pain, right? So we have signature in the lung, we have signature in the joints, and we have signature in the skin, right? And so I think through my autoimmune conditions that can cause that, what are they? So I think, as you said, vasculitis, 100% can do that. I think in this young person, we've had a couple of cases over the last few months of inflammatory myopathies, and certainly this would fall under that spectrum for sure. This is similar to Kirtan's case. This is similar to Vijay's case. So I think that's a definite consideration. And then, spondyloarthropathies, psoriasis, absolutely, it being one of those could certainly cause this. I don't typically associate pulmonary manifestations with that, but I imagine that's like a knowledge gap for me. So I'd probably be investigating if that's something that people have seen or investigated. So that's where my mind is at right now. I mean, I think it's impossible to make much progress beyond what we've made already without additional exam data to confirm what we're saying. Like if I'm translating this to synovitis, but maybe it's not synovitis, maybe it's something else, as we talked about before. So I think the exam will be powerful. We know this patient's going to receive a lot of lab work, and that'll help us as well. And then probably some imaging of the lungs for sure. So really great case so far. Excited to hear more.
Can I just add one more thought here? I saw in the chat that a friend of ours just I can't remember the name mentioned infective endocarditis as a unifying diagnosis for all of these symptoms, like subacute endocarditis with 1 month of inflammatory tail. I think that could fit in the picture here, manifesting in the joints through emboli, like flicking of emboli. And one thing that maybe decreases that possibility is you mentioned that in the cardiopulmonary exam, the heart sounds, I think you mentioned there were no like extra heart sounds or murmurs or anything. I'm not sure if I recall this correctly, but I feel our physical exam is not always 100% accurate, and would like to see like echo, further imaging, and I think blood cultures would be important here as well to address subacute infective endocarditis.
That was a wonderful thinking process, very stepwise, a very stepwise approach. So we were thinking along the same lines. The infectious and the autoimmune rheumatologic conditions are primarily the main differential in this case. And I think the physical exam is what then you need to focus on to further divide the differential diagnosis. So we're gonna go ahead with that. When he presented to the admission, to the ED, the admission vitals were kind of significant. He was very tachypneic, very tachycardic. The heart rate was in the 130s. Respiratory rate was 26 to 30s. The blood pressure was okay, 100/70s. He was also hypoxic, saturating 91% of room air, improving to 99 on 2 liters of nasal cannula. General appearance was a very thin built male, respiratory distress with some nasal flaring when talking. Cardiac examination, he was tachycardic, but the rhythm was regular. No murmurs, no rubs or gallops, or no JVD were noted in the cardiac examination. Pulmonary wise, he had some scated bronchi, decreased breath sounds on the left lower lobe. Abdominal was unremarkable, soft, non-tender, non-distended. And when you come to the skin exam and MSK exam, I'm gonna share some pictures so you guys can see, and maybe we can narrow the differential based on the skin examinations. Okay, so this is, you can see here 2 rashes actually. First, in the scalp, it was a scaly erythematous rash. And also, he has some heliotrope rash with no nasolabial sparing. You can further appreciate it here in these images. He also have these signs in the arms, in the fingers. We're going to see it here. So there's some erythematous patches in the forearms, distal fingertips. You can also appreciate some violaceous plaques here. And when you see his hands, also he has in the knuckles some erythematous rash here, which there's kind of an specific sign. You guys probably know this already. And I want to hear your thoughts now. with this new information in the physical exam.
All right. So when I first look at the vitals, we heard that the patient has hypoxia, tachycardia, and no murmur, rubs, or gallops were appreciated. And the patient had decreased breath sounds in the left lower lobe. What the vitals are doing for me is that in a young patient, first I look to understand whether the patient is sick or not sick, and it seems like the patient is very sick because the tachycardia, the heart rate being in 130s, that's very concerning. Also, the oxygen saturation being 91% is also really worrisome. So this patient appears to be very, very sick. And with the skin findings, you mentioned that the erythematous patches on the face was on the forehead and it was on the cheeks, not sparing the nasolabial folds. So the rash on the cheeks, we are familiar with SLE causing like malar rash, for example, on the face, but that usually spares the nasolabial folds. So I'm trying to think of like what could be other diseases that are not sparing the nasolabial folds. I cannot think of like anything particularly right now, but the hand findings, I saw the picture and I interpreted it as like the hands were kind of like the skin was tight, almost like what we see in the CREST syndrome in a variant of systemic sclerosis, but I wasn't sure like if that was the case for this patient, and I'm very excited to hear from Dr. Austin about that. And yeah, those are my initial thoughts to begin with. What do you think, Dr. Austin?
No, I think you've made a really, really good start. And I mean, I think, again, it speaks to the power of the exam, and it's wonderful how detailed exam was done. And I think if we step back to the patient when they went to the emergency room previously and got their treatment for CAP, maybe if and maybe that wasn't seen. I can't promise that it was there, but I imagine given the longer tail of this, probably there was at least some aspect of that was there. Maybe we could have helped this patient arrive at a diagnosis sooner. So I think kudos on you guys for doing such a good exam. You know, if I, Tantu presented, if I sort of frame this to you in a different way and said, they were describing a patient that was a young woman that had a rash around their eyes, a rash around their neck and chest area, and then their hands look like they had a profession maybe with like taking care of automobiles. What would you describe that as? What comes to mind? Is there a particular diagnosis that comes to mind?
Right. I would think of dermatomyositis in such a patient.
Good. Yeah. And I think a lot of the skin findings that we're seeing are potentially consistent with that. I forget all the names, but I think this is Gotran's sign or papules, the extensor surfaces of the arms. I think we're seeing mechanics hands. And then you can have a rash of the scalp, and you can definitely have a central rash of the face that can mimic like lupus, for example, though, as you mentioned, there's no nasolabial sparing. So I think there's certainly a differential for that rash. I don't, every time I see it, I just sort of look it up because I don't remember it, unfortunately. But I think all those things together in combination with the patient's other symptoms make us concerned about that this person has an inflammatory myositis for sure. So I think that's the path we're going to be going down, which, to be fair, I mean, you already got there, right? It's wonderful to see these signs, but if you didn't recognize them, you're going to say, hey, I'm going to ask for help. But you were already, barking up the right tree in that sense. So you don't have to always know every single sign of every single disease because that's impossible. Like we just don't know, right? But you know enough to say, hey, this smells weird. This is not community-acquired pneumonia. This is not some, typical infection. What else could it be? And you went looking for other signs and you found them. And so I think we don't need to beat ourselves up about the things we don't know. We just need to we just need to recognize when we don't know something, and then we can make progress. So I think that's wonderful that you did that. So, going back to the endocarditis that you mentioned, I definitely thought about endocarditis too, and it can certainly sneak up on you, and we've seen a few cases of that quite a few times. But I think if I step back and say, okay, what is this person's risk factors for endocarditis? They really don't have any, right? They're not old, so they don't have like degenerative changes, presumably. They don't have a lot of behaviors that would make them high risk to get an infection. And then the initial syndrome, there was no like recent infections that we could gather to give us a sense of like what's this person's risk of endocarditis as a normal host. I guess we could look in their mouth and make sure their teeth weren't absolutely in disrepair. But I think that was why I was sort of lowering a priority of endocarditis. But 100%, it was definitely a big thing to bring up, and you certainly don't want to miss that. But to your point again, like the cardiopulmonary cardiopulmonary system was already on the hook. And so I think ECHO was going to come this way one way or another, and hopefully we can make progress that way. But no, great thoughts. As far as how to make progress in dermatomyositis, I don't want to commit to that quite yet. I think we'll wait for the labs and go from there. Whenever I see hands plus lung issues, it seems like there's okay, so there's reduced sounds in the left lower base, so that could be evocative of like a pleural effusion, which I don't typically associate with the lung findings of dermatomyositis or like antisynthetase syndrome in particular in this person. So I think imaging is going to be helpful to us. And then what other labs might you get for this patient, Tansu?
So first of all, I just want to make comment when it comes to the left lower lobe consolidation and the idea of dermatomyositis. If I'm remembering this wrong, please feel free to correct me, Dr. Austin. But I thought in dermatomyositis, we search for maybe an underlying malignancy, and the left lower lobe consolidation kind of made me think like, would there be can this be a malignant consolidation in this patient's left lower lobe? I'm not sure. The patient's age being so young is kind of like steering me away from that thought. But I just wanted to like put it out there and check with you what you think of that. What kind of labs would I get in this patient? First of all, of course, I would get the basic CBC and complete metabolic panel, but I would be also very interested in, like, since we have the idea of dermatomyositis, the specific and non-specific antibodies of dermatomyositis comes to mind. And the non-specific ones are more sensitive, and the specific ones are more specific, but they're less sensitive. And I cannot name them off the top of my head right now. I would be going to Google and Googling those antibody specific and non-specific ones. But those would be the things that I would check to begin with.
Yeah, awesome. I don't remember the antibodies too. Robbie and Kirtan and Vijay like shared those cases, and I like have a little like part of my notes where I've written them down. I just cannot remember them to save my life, so I would be looking them up as well. I think to your point, like I'm not going to commit to this diagnosis yet. Like I'm going to do a full sort of autoimmune evaluation. ANA, our sort of workhorse of autoimmune disease, which can be positive in patients with dermatomyositis or inflammatory myopathies. And then probably do the lupus evaluation as well, because again, you could have overlap syndromes for sure. And then we can't forget about our infectious bucket as well. So definitely, as you mentioned before, we're going to check blood cultures, because this patient is systemically ill and technically meets SIRS or criteria. And if we didn't have the rash findings, we'd probably treat this patient with empiric antibiotics as they have sepsis. And then imaging of the chest. And what type of imaging would you get? We'll give you the x-ray, because everyone gets an x-ray, whether or not they came in with any sort of pulmonary complaint or not. But what type of imaging would you get of this person's lungs?
Right. I'm not even sure like if I would get a x-ray in this patient, because I feel like x-ray would be too basic for a patient presenting with such severe symptoms. And following Robbie's footsteps, I think I would get a CT in this patient to characterize the left lower lobe consolidation, to just see, the left lower lobe of the patient, we don't know if there's a consolidation yet, but because of the reduced lung sounds in that area, to see the character of that left lower lobe, what's the situation there? I would like to see that with CT first.
Yeah, no, I agree. In the United States, where we have the resources, like an X-ray probably for insurance reasons, but then certainly in order to make the appropriate progress that you need, then a CT scan, absolutely. I think to your point, like we would probably evaluate for malignancy as well. This person doesn't meet like the sort of there is no age appropriate malignancy screening for this patient because they're so young. We would have to really, really focus on the family history, which it sounds like there's only diabetes, so there's no sort of early cancer history to suggest that we need other types of screening, but probably a pan scan would be in their future. Maybe I would like to say I would start with a high-res CT, but in real life, probably I wouldn't. It would probably just be a CT chest, abdomen, pelvis, like with and without contrast is probably what I would do. But no, so much rich teaching here. So excited to hear more about the case.
Thinking about on the lives of dermatomyositis and polymyositis, one of the key aspects in the physical exam that I forgot to mention was neurological weakness symptoms. He didn't have any weakness signs. He had a pretty good power in all extremities. Also for the MSK exam, he had some synovitis in the MIPs, diffuse synovitis, MIPs, PIPs, and also some tenderness in the wrist, but no synovitis in the wrist. Okay, and for the labs,
Yeah. So like just further expanding on the physical exam findings, like Alberto mentioned. So he had the synovitis. He also had this erythematous plaques over the extensor surface of his MCP joints on bilaterally. He also had some so like Dr. Austin mentioned, right? Mechanics hands
oh yeah.
and Gorton papules. That's all something that we noticed on our physical exam, and that's also was documented on our chart. So then we'll do the we'll go to the labs and the EKG and the imaging that we got initially. So we'll just speak about the remarkable relevant labs. So we did a CBC. So it was pretty okay, but what we found that he was mildly anemic. So he had a hemoglobin of 11.6, but no leukopenia, no thrombocytopenia. The leukocyte count, the neutrophil percentage was 75%. Eosinophil count was normal, so there was no eosinophilia. His renal function was okay. His BUN was 6, creatinine was 0.47. The electrolytes were fine within normal range. His LFTs were normal except for albumin of 3. So he had some hypoalbuminemia. Because he was having these respiratory symptoms, he also got a swab to test for COVID, RSV, and flu, which was all negative. Given the fact he was the symptoms, the spectrum of symptoms could also point to a cardiac etiology. We got troponin and proBNP, which was again not elevated. The coags were normal. The PTNR and APTT was normal. Now, thinking on the lines of a rheumatological condition, we also obtained CRP and ESR. So CRP and ESR were slightly elevated. CRP was 9 and ESR was 27. Given the fact that like how you discussed beautifully before, like dermatomyositis and those spectrum of disorders are in the differential, so we also got CPK to see if there is any muscle involvement. So the CPK was not elevated, so it was normal as well. We'll go to the EKG. So the initial EKG showed sinus tachycardia with a heart rate of around 131. He also had P pulmonale, tall P waves, especially in lead to pointing to a right atrial enlargement. And he had some inferolateral T wave, non-specific T wave changes. The X-ray, and I agree with what Tansu said, CT scan would be a much better diagnostic and imaging tool here, but you go through an X-ray first. So we got an X-ray and it showed left lower lobe infiltrate. So, and this was followed up by a CAT scan, which I'll describe now. So we got a CT chest PE with an angio just to rule out any pulmonary embolism, given the fact that he's been having chronic symptoms for a long time. Maybe he had a chronic PE, causing these respiratory symptoms. So we got the CT scan, and it showed that he had the left lower lobe infiltrates. So the left lung showed left lower lobe infiltrate, which were both alveolar and interstitial. There was a left upper lobe and lingular interstitial infiltrates, no alveolar infiltrates in those lobes. And the right lung had right lower lobe ground glass opacities. So this was what we found on the chest CT. Any thoughts?
All right, such rich information. Thank you so much for sharing. I was just trying to reflect on it as you were giving us all this information, but I'll just start with my initial thoughts and I'll see what Dr. Austin will add. So starting with the chemistry of the patient. So when I think about in inflammatory states, I look at albumin, thrombocytes, leukocytes. So in this patient, the CBC seems to be normal, except for the slightly low hemoglobin. But the patient has low hypoalbuminemia, which may show that the patient had been having this inflammatory state for for a couple of weeks, for a long time. That's why as a negative acute phase reactant, the albumin fell. The CRP and ESR, CRP being less elevated than ESR. So how I think about these two parameters is that ESR is more subacute than CRP as far as I know. So CRP would be elevating in the acute phase, and then ESR would be increasing right after. The ESR being higher than CRP here, it's showing me that, again, just like hypoalbuminemia, the process has been ongoing and the patient has a subacute to chronic inflammation in his body. And then the CPK being normal, I think I would expect CPK to be high in dermatomyositis. And but I saw some friends mentioning in the chat that there's also a CPK normal variant of dermatomyositis with the anti-MDA 5 positive type of dermatomyositis, which is called the amyopathic type. And when it comes to the lung findings, so first, we saw that the patient had a reduced left lower lobe sounds in the lung, but now we also see that there are ground glass opacities in the right lower lobe of the lung. So it seems like there is a diffuse process in the lungs. And when I think about ground glass opacities, I think about them in terms of acute and chronic GGOs. So in the acute phase, I think about blood, pus, or water. And in the chronic phase, my differential expands to include protein and cells as well. I'm not sure what this patient has in this case. And I'm still prioritizing dermatomyositis here, especially the amyopathic kind of it with anti-MDA5. I don't know much about this disease entity. And I would like to hear more from Dr. Austin.
No, incredible synthesis. I really don't have too much to add. I think you're right on about, I'd say if we step back and say do the labs help us make progress? I would say no, not really, right? I think we know that this person was inflamed before. The inflammatory markers are maybe not as dramatically elevated as we would have thought, but I think even if the inflammatory markers were normal, it wouldn't move the needle for me that this person isn't inflamed. I've been fooled by that quite a few times, or we feel reassured by normal or only mildly elevated inflammatory markers. I think we're very often in the scenario where it's oh, well, let's see if this person's inflamed, and we get the inflammatory markers and they're mildly inflamed. But in this case, where the patient is absolutely on fire with their body, the inflammatory markers really don't help us make too much diagnostic progress. And then to your point, I think we're saying they did a nice evaluation to say, hey, we think that there's an autoimmune or non-infectious etiology, but let's double check to make sure, because this person has infiltrates on their imaging. Why couldn't we think they have an autoimmune disease? That's some level of immunosuppression. So they certainly could be a setup to have a secondary infection. So I think all of that was very, very appropriate. But under revealing, fortunately, So I think, the CK, as you mentioned, the nuances of that. Sometimes if you have more chronic disease, I suppose the CK or the aldolase or other muscle markers could be basically the disease sort of gets burnt out, and so you don't really necessarily have numbers. Or you're having a variant that is not elevated, and as you mentioned, the one that I'm familiar with from VMR is the anti-MDA5, and this is a pretty good patient epidemiology for that. It's a young person, no history, no muscle disease, that we were recognizing, but prominent and sort of progressive pulmonary and articular signature, that's what I was trying to say, in the joints, right? And that fits well with this particular disease entity. So as far as making progress on the CT, I think we were worried about consolidation, as you mentioned before, and I think we didn't really see a frank consolidation or a mass for a malignancy, as you mentioned. We didn't see a pleural effusion, which I was initially worried about and trying to, incorporate that into my problem representation. But I think if we step back, all of these findings, I think, continue to support the hypothesis that there's a diffuse interstitial disease. It might be an area of the lung where it's worse than the other, but not enough focality for us to invoke that there is a secondary diagnosis going on, or that we're barking up the wrong tree. That's my general synthesis. Otherwise, I think you did an amazing job covering everything else. So let's keep going.
All right, so at this point, we do have some differentials, and you guys already outlined it very well. So we still cannot rule out an infectious etiology. So we still have that in the differential. So it's either community-acquired pneumonia or some other infection such as TB or diffuse fungal infection, which has had some atypical presentation. And obviously, it's a connective tissue disorder or malignancy. So then patient was admitted to medicine floors. Initially, we started him on the pneumonia treatment with ceftriaxone and azithromycin. Given the wide range of physical findings, we had dermatology and rheumatology as well as pulmonary medicine on board. Patient was started on. So once we had recommendations from every specialty, we started a patient on high dose pulse steroids for 3 days because our suspicion for connective tissue disorder was at the topmost of our differential list. For the rash, we started him on clobetasol, like steroid creams, and the rash improved with that. Once he was beyond the 3 days of pulse dose steroids, we switched him to prednisone 1 milligram per kilo. So for him, it came to around 60 milligrams of prednisone daily. But there was some twist, okay? Okay, so I forgot, before while we are also starting him on steroids and antibiotics, we also send an autoimmune workup. So we send ANA, and we send we have a test like ANA with reflex. So if it's positive, it tests for all the lupus antibodies. We also send the antibodies for rheumatoid arthritis. We also send ANCA and the myositis panel. So given I'll discuss the findings. So we had ANA was positive. It was the titers were 1:320. Aldolase was negative. CK again remained negative or like normal. All the lupus antibodies were negative. Complements were okay within normal range. Rheumatoid arthritis workup was negative. All scleroderma antibodies, anti-centromere and anti-SCL70 were all negative. We sent the vascularis workup, so we had negative C ANCA, negative P ANCA. Atypical ANCA was indeterminate, but it was not like strongly positive. And the myositis panel we sent, it took a while for it to come back. And we'll discuss that down the line, what the myositis panel did show. But 5 days into the steroid course, we had a complication. Patient developed atrial fibrillation. It was around nighttime. He developed rapid heart rate going up to 180s. Telemetry showed atrial fibrillation. He was given metoprolol, initially 2.5 milligram IV, followed by 5 milligram IV push, which did not resolve the atrial fibrillation. So he was given cardizem 25 milligram, that's diltiazem, and then started on a diltiazem drip. and then he was transferred to ICU. He was then evaluated by cardiology, and at the same time, we again set the cardiac biomarkers, troponin, proBNP. We also sent TSH because you also want to rule out hyperthyroidism as a cause of atrial fibrillation. The TSH was negative. The cardiac biomarkers remained negative as well. Cardiology saw him, and his CHA2DS2-VASc score was 0. We didn't start him on any therapeutic dose anticoagulation yet. He was eventually tapered off the cardizem or diltiazem drip, and he remained in sinus rhythm since then. Our thought, or before we say our thoughts, so what do you guys have in mind regarding why he developed atrial fibrillation?
Should I go first, Dr. Austin? Okay. So, why the patient had atrial fibrillation? I honestly don't know. I can't comment on that. But the antibodies being negative, we still didn't hear about the anti-MDA5, so I'm still waiting to hear about that one. So maybe Dr. Austin can comment on why we saw atrial fibrillation in this patient, and then maybe I can share my thoughts later on.
Yeah, this is an odd gap for me. I don't typically associate, there are many myositis or many myopathic disorders or muscular dystrophies that do involve the heart. I don't typically associate dermatomyositis by itself with cardiac issues, but that's something I'd have to look up. I just think about the base rate of atrial fibrillation. It's so common, and this patient is stressed. The heart is stressed. And so, I would think about, could this just be related to that? That being said, the patient is 23 years old, doesn't have known structural heart disease. So isn't the classic person to develop atrial fibrillation like the 70-year-old that has pneumonia in the hospital, as we mentioned. So then we go to like, what things have I seen? When have I seen young patients get atrial fibrillation? And usually it's some sort of exposure history. So like, is there amphetamines, for example? We've seen that. Certain drugs. One of my own co-residents like drank a bunch of coffee and energy drinks, had atrial fibrillation. And then, I would wonder about the steroids. And I'm not sure if that could be a predisposition to developing atrial fibrillation. I've never personally seen that, but maybe in combination with some smaller, subtle amount of cardiac inflammation related to the myositis or an overlap syndrome, then I suppose that's potential possible. But other than that, I really couldn't make too much progress. I'd be leaning on my cardiology colleagues and then discussing, whether or not like a cardiac MRI would make sense. I would say that, if the high sensitivity troponins were negative, I mean, that really speaks strongly against that there's some sort of something infiltrating the heart because the test is so good. But this is a stretch for me. I don't know. I'd be excited to learn. But those are my thoughts in particular about the atrial fibrillation, but glad we were able to get it under control.
Yeah, so we were also thinking along the same lines. We had a transthoracic echo done, and it did not show any structural heart abnormalities. Even the right-sided pressures were actually pretty fine. His EF was 55%, so no reduced EF. And the AFib sort of spontaneously resolved. So our thought process, one of things was that he was still on nasal cannula, so maybe some hypoxia causing some sort of arrhythmia. And the other thing that we actually read up online and what Dr. Austin was saying is the high dose steroids. So there was an article from JAMA in I think 2006 where they had described atrial fibrillation in patients receiving high dose pulse dose steroids. So that is what we thought it was, and it did not recur again. So eventually he was downgraded from the ICU, and he came back to the floors, and the atrial fibrillation never happened again, and he did not require any calcium channel blockers or beta blockers throughout the admission. And by this time, we also had our blood cultures, sputum cultures, everything sort of started coming back. So all the infectious workup that we had sent previously came back. So the blood cultures were negative. Sputum cultures were negative as well. We also tested for Legionella. So we sent Legionella urine antigen. We sent for fungal workup, we sent histoplasma urine antigen and beta-D-glucan, galactomannan, test for this odd, because we don't know, because he said he was coming from DR and he said he hasn't traveled anywhere, but we still wanted to rule out coccidioides, blastomycosis, and everything turned out to be negative. We also sent an extended viral panel, respiratory viral panel. So initially we only tested him for flu, RSV, and COVID, but we sent an extended viral panel which was also negative. Quantiferon we sent, it was negative. The interferon gamma release assay for mycobacterial tuberculosis was negative, and the sputum AFP stains were also negative. However, once the patient was discharged, we had the sputum AFP cultures back, and it actually grew MAC, Mycobacterium avium intracellular complex. So that grew in his sputum AFBs. But later on, it took around a week for the myositis panel to come back, and you guys were all thinking along that line, that he had positive MDA5 antibodies. So he was already on steroids. Our plan eventually was to start him on a steroid-sparing agent, either mycophenolate or azathioprine. And then, once he starts feeling better and once he was off the oxygen, we discharge him with outpatient follow-ups. We also had a malignancy workup done, so a CT abdomen pelvis to see if there are any malignant or any suspicious masses there. He was also evaluated by GI, who did endoscopy and colonoscopy, and there were luckily no masses there. We referred the patient to another hospital, the Hospital for Special Surgery here in New York, which they are really good in rheumatological and musculoskeletal disorders. So our rheumatologist is also following the patient, as well as now his primary care has been shifted to that hospital.
Wow, what a case. And I know what I'm doing after this VMR. I'm going and studying anti-MDA5 variant of dermatomyositis. This was amazing. It was a very thorough presentation. Thank you so much for bringing this wonderful case to us and teaching us. And thank you so much, Dr. Austin, for helping me all along the case and teaching me a lot.
Well, I didn't help at all. I was just here, and Tansu, again, I just can't speak to all the IMGs here and VMR. I mean, you guys are just absolutely incredible. On par with any medical students I've ever worked from anywhere. So superb, excellent discussion. And the case, truly incredible. Thank you so much for preparing it. I can't imagine how long it took to sort of organize everything in the way that you did, and all the thorough evaluation that you did. And I think, the patient was so lucky to come to your hospital, and you guys take care of him, because, this diagnosis could have been missed for even longer, and could have been, I think, for this patient whose body was really suffering, I think getting them on immunosuppressant as soon as possible could really make a big difference for them. So I'm glad that they had you taking care of him, and that you were, really thinking through the case, and not just saying, oh, it's another case of pneumonia, which I've seen happen more times than I care to admit, unfortunately. So kudos on you guys. And I'm sad to not be able to hear more about your program. I have to go take care of my son. But thank you again so much for the case. Thank you to Tansu for carrying the discussion and making many amazing points. Thanks to Vijay and to Bettina for working the board. And I'll see you guys later, and I'll pass it over to the rest of you guys.
Thank you so much, Dr. Austin. And I can kick us off with questions. So you're a New York City program, and I also applied for programs in New York City almost exclusively. And I'm very curious about what are your favorite aspects of training in a New York City program, and what are some disadvantages, if you want to talk about that. So just a general overview of training in a New York City hospital would be great.
It has been a great experience training here in New York, having such a diverse population. You have exposure to multiple diseases that you won't see anywhere else. in the United States, things that are not common, like tropical diseases, CV, things like that. Is something that you get to see on a daily basis, and it's something that I think, based on the city, and can only happen here. Also, you have so many other things to do outside and opportunities to create another side of you and grow that aspect of not only the medical part. And I think that is for that reason I love training here. I think it's a great city to do medical residency.
Yeah, and I would like say the same thing, right? New York, being New York, it's like the capital of the world in many aspects. And then you have people from every place around the world who are here and residing here, working here in New York City, and then you get to a chance to see them. So the diversity in the ethnicity and the racial distribution is vast. The diversity in the pathologies that you will see here is vast. That really, enhances your training. Like he mentioned it, when we were doing studying for our USMLE exams, you would have a case of a patient coming from, let's say, Africa or India, now having fever, and then you would be thinking TB. But when you go to practice somewhere else in the United States, you might not really see those presentations. But here we actually see we have a lot of patients who are being diagnosed with TB. I'm from India, so like, yeah, the first thing if a patient comes to you with fever is you're thinking malaria or dengue, and we also think that here that's still there in our differentials. We are not forgetting that the malaria is not out of the picture. It's still there, and we still I'm right now I'm rotating with infectious diseases, and just 2 days ago we had a patient who came in with malaria. So the you never run out of cases to see. We see a lot of common conditions as well, like a bunch of our patient population have these chronic conditions like COPD, asthma, and CHF. But if you go to let's say you see the statistics, we are from South Bronx, and we have the highest population of asthmatics in this small area. We see a lot of asthma, and we see really severe asthma. And the fact that we get to see such patients, the fact that we get to treat such patients, I mean, it's a wonderful experience, because you see so many severity, from like really basic asthma to really bad asthma, and like you learn a lot of things. So I think that's the beauty of our program, that the diversity is immense, and I think even in the common cases, you're sort of learning something new every day.
The acuity index is also pretty high. The patients have a lot of comorbidities combined, sometimes all of them exacerbated and with something else on top of that. So that really makes your practice, your experience you get much more experience seeing those sort of patients.
That's really amazing. I don't know why this sign is showing up next to my face, the thumbs down. I'm sorry about that. I'm not making thumbs down or anything. It's one of the observations that I made about New York City programs too. Not only you get exposure to bread and butter of medicine, but also very unique cases, because there's such diversity, both in terms of population and pathology. And when you also see the bread and butter of medicine, you see a range, not just the typical presentations, but also very atypical presentations. So I'm very, very excited to train in a program in New York City because of this reason as well. So if we have other questions from other people participating in the chat, Yaz, would you like to ask those?
Oh yeah, I think I can do a question here. Brian's asking if the medical center is linked to that in Nebraska.
No.
They're different. Okay.
Yeah.
Well, I do have a question normally for residents that go into fellowship. Like, do you have mentorship opportunities to improve your fellowship match? How is it?
We do have a official mentorship program you get paired with your attending. You can choose within the first month who is going to be based on your preferences. Let's say you want to do cardiology fellowship, pulmonary fellowship, you get paired with an attending, and you develop the relationship with your mentor. There's a specific times and the program focus on you throughout your career, so you can keep doing the steps that you need to do for your fellowship. So we also have a mentorship program based on you also get assigned with a senior that is gonna guide you towards the things that are more like common daily life sort of things. Or any advice that you will need throughout the residency, you also get your third year that is there to guide you. I see one question in the chat if there's a focus integrated in the program. We do, and we actually are very proud of that. The training, the focus training, since I came here to Lincoln, I felt it was pretty strong. All my seniors were using it. All my attendants were asking for the findings or like, did you perform the focus? It has become such an integral part of our program, and I think I have really enjoyed that. You get training and you get the opportunity to practice on a daily basis. You have a lot of opportunities since we have a lot of machines here in the floors and also in the ED. So anytime that you have an admission, we do the focus. Anytime they have a patient on the floors, you get the chance to do focus. So that is something really nice.
And with the availability of the focus machines that we also have a lot of emphasis on procedures. So you actually get really good hands-on experience with procedures such as, lines and, you by your second years, a lot of residents are sort of independently doing lines. We also always have an attending or a third year watching over them. But I would say confidently that, by your mid second year, you're always confident with doing lines and procedures. It's not that you're going to be scared of any procedures. And yeah, that's wonderful, because for me, I wanna go into Palmcrit, and to have this opportunity available to me and to enhance my skills, that's wonderful.
Thank you for giving us this great information about it. I think Deb had a question about like research. What do you think, Deb?
Yeah, we always get questions about research, and in the program, you all have time and have opportunities to do research.
We do, and we're actually also pretty proud of our research department. It's under the guidance of Dr. Menon. She's a research director, one of the APDs. We have multiple projects going on since I've joined here at Lincoln. I have the opportunity to join and start my own projects, and you have the time. We do have also an optional research rotation if you wanna invest your time in that. But along the line, I felt that in the past 3 years, you have the time, you have the resources to keep doing any research work that you may be interested in and that may support your fellowship. Multiple of our residents are involved in these projects, not only like clinical research, quality improvement projects. Sometimes we're actually sometimes I had the opportunity to participate in some qualitative research, and that was pretty amazing.
Yeah. I see there is a question about the cost of living in New York City, and it's a very valid question. And yeah, it's the cost is high. Okay, no lying there, no making up any excuses. Yeah, the cost of living is high. So I think one thing that if you join a program in New York City, you'll get good with your financial management. But we also have a union, so all residents are part of the union, and union is actually, fighting for increased pay, and they have a meeting actually next month for that. Hopefully, it'll come around, but yeah, the cost of living is high there in New York. But the thing is, in New York, there is something for someone always. So it's a wonderful city. If you want to come and stay in New York, I think at least once you should stay. It's the best city. Like,
That being said, I think with the salary that you get during residency, you can get a comfortable living. It's not an issue in that sense. It's true, it's expensive, especially the rent has been going up in the past few years. Since COVID, it has been going up. So that is one of the things that location-wise can be an aspect that you need to consider. But yeah.
Yeah, it also depends on which part of the city you decide to stay. So if you are going to live in Manhattan, obviously your rent and your cost of living will be very high. If you stay in Harlem, Upper East Side, or Bronx, your rent might be lower. So it also depends on where you stay and then how you commute.
Thank you so much. As a person living in New York City, I can also speak to the, very high living expenses in this city. But in the end, hopefully I will get a great training and you're getting a great training. So it's just a trade-off of that. Thank you so much for the great case that you brought to us and for all your answers. Just to be mindful of everybody's time, I think we are going over time a little bit. Maybe we can end our session here. Again, thank you so much. And we hope to see those who can participate in tomorrow's Fundamentals of Clinical VMR tomorrow. All right.
It has been a
Bye.
wonderful experience. Thank you very much, all.
Okay. All right.
Thank you.
Bye-bye.
Bye bye.
Thank you for joining us.